Hi, welcome to Detours, Understanding Acquired Brain Injury. We've talked about medical professionals a lot on Detours, but it's important to understand how they're educated, what they do. We will start our Medical Mondays coming up talking about physicians, surgeons, and other medical professionals. And because we're focusing on the different medical professionals and how they help acquired brain injury survivors, it's important for us to touch on their education and what their focus is. So what we'll do is we will have an initial episode where we'll talk about their education generally, and then we'll talk about those specialists, which are those who focus on helping people with acquired brain injury. For example, brain injury medicine physicians or epileptologists, or epilepsy nurses and rehab nurses or other kind of specialists, physical therapists, so forth and so on. But to get this started, our focus will be on physician education first, and then we'll go from there. So hopefully you find this helpful and informative. We have talked a little bit about physician education in the past, but now we'll kind of get a little bit more into the weeds. So hope you find this helpful. All right, so the basic question is, how do you become a physician in the United States? How does it actually work? You've seen TV shows and everything else, movies and such, but how does it actually work? Let's start. If you want to become a medical doctor or doctor of osteopathic medicine, there are two kinds of medical schools in the United States. The allopathic medical school, which teaches somebody to become a medical doctor, or the osteopathic medical school, which teaches you to become a DO. Now, these days, there's really not much of a difference between an MD or a DO. Now, yes, there'll be those who would throw tomatoes at me for saying it, but the truth is, when it comes to what standards they have to meet, it's defined by the state. And so the privilege to practice medicine, and it's a privilege it's no one's right to, is clearly defined by the states together, and they've really just said these are the criteria you have to meet. And so there's not much of a difference. Major difference is that the allopathic medical schools aim their students more towards becoming specialists, surgeons, that kind of thing, whereas the DO programs tend to aim more for family medicine, a holistic approach, the more integrative medicine, that kind of thing. But apart from that, really, the differences are fairly subtle. Yes, we'll talk about that a little more, but for the most part, MD, DO, same thing. Again, I know there are definitely differences, but these days it's like very subtle because of the law and because of the Medical Practice Acts, which really define what it takes to be a physician in the United States. Blah. Okay, so, how does it all begin? It all really starts when you're in your undergraduate studies. The first thing to understand is that as a prospective physician, you may major in any course you want, any course of study, from mathematics to underwater basket weaving. It does not matter. What does matter is that you take the right science and math courses that form the basic prerequisites for medical education. For those of you in high school considering medical school, one thing to bring up: AP courses, advanced preparatory courses, they do transfer, and medical schools will acknowledge them so long as they transfer to your bachelor's, to your Bachelor of Science or Bachelor of Arts or whatever. So long as the undergraduate school recognizes them, and so long as it makes part of your GPA, gives you the necessary grades that the medical school expects. CLEP courses do not count for most. Again, there are asterisks here, but for CLEP, those don't count. Now, there may be the exception out there, but for the most part, AP, yes. CLEP, no. Also, when you are taking university courses, if you take, community college classes, or you take any other on the side or whatever, it must be a science-based lab-based course, either algebra, calculus-based science courses with the labs. Sorry, no rocks for jocks or any of that kind of stuff. It's got to be a science-based lab course. Chemistry, inorganic chemistry, you got to take that. Organic chemistry, you got to take that parts 1 and 2, 1 and 2 with lab. You got to take physics 1 and 2. Don't go too far in the other way. That they won't accept either. So if you're taking astrophysics or building an atom bomb, no, they don't take that either. You can go too far in the other direction, because if you're taking something super specialized, they'll be like, what are you supposed to do with this? Go join, like the Department of Energy, DARPA, whatever. You can go too far in the other direction. So just keep it in mind. Undergraduate students must be prepared to enter medical school with this solid background, and the focuses should be biology, chemistry. They also want a solid background nowadays in statistics. It used to be, hey, just take a pre-calc and a calc or whatever, and they want you to have a solid grounding in stats, since more and more medical schools are relying on the science or the research programs, research that their students are doing, as well as their senior professors. So stats, basic and advanced stats, that matters a great deal also, and affects you getting in. So make sure you have the stats. So many students come from high school with calc already and everything else, and it's just like, statistics matters. So they're looking for, do you have stats? Again, check the schools you're interested in. They will outline what courses they expect. You also need to have technical writing or, research writing, that kind of thing. And you need to have psychology, sociology, that sort of thing, because that also affects acceptance and, how you getting in. Understand, that pre-med is not a major. There is no major called pre-med. There may be some strange exception, but generally it is a track in the sciences. Just to make sure that you get all the necessary courses if you're interested, maybe the healthcare track or whatever. For like if you want to do physician assistant or whatever, the same kind of thing, they generally want the same kind of courses. So, honestly, so just make sure you've got those prereqs, and the grades you get in sciences is often even more important than your general GPA. Again, check the school, see what they want. So any major? Yes, any major, so long as you have the sciences. Are humanities majors accepted to medical school? Absolutely. In fact, humanities majors are the most likely to be accepted to medical school. Again, it's that rounded student. Music majors, in fact, have the highest acceptance rates of all majors that are accepted in medical school. Full stop. And that's corrected for the number that apply. Now, math majors do have the highest MCAT scores. Shouldn't surprise you. But when it comes to music majors, 66% music majors who apply are accepted. What it tells you is that it's the mental discipline. It's not, I'm not smart enough or whatever. It's that cognitive, that mental discipline for study. And we all know, how obsessive some of those music majors. I know, good student and all that kind of thing, right? But seriously, it's mental discipline. You don't have to be a genius. You just have to have the discipline that it takes. And you know how I feel about the word genius out there. Those of you who've watched my videos know how much I hate that word, but because it's, it's a pop psych kind of thing, and, but mental discipline, cognitive discipline is key if you want to get into a medical school. You need to have the focus and the discipline that it takes. And this really is what it's about. And it's the same thing when it comes to the MCAT too. It takes that cognitive discipline. And yes, you actually need to do well in your coursework, but that the rigor and the mental discipline is essential. Always check, especially if you've made it this far in the video, suggest that you have that mental discipline for something like this. All right, so we discussed the recommendations, which are actually requirements, but beyond the inorganic and the organic chemistry and the biochemistry, which now they're starting to require more for students coming in. They used to teach it, but fewer and fewer schools are saying, oh yeah, we'll cover the biochemistry when you come in. But again, some do. But they more and more want you to have the biochemistry already. They want you to have volunteer experience, whether it's in healthcare or whether it's, helping other people. Again, they want to show you that you have that empathy, that you have the care and compassion, that kind of thing, that you more than just memorized facts. So it's important to have volunteer experience. A lot of EMTs and paramedics who go on to medical school, that kind of thing, they got their EMT or medic in order to help, with that rounding kind of experience, or working in a soup kitchen or, that kind of thing, did that. Doing it in high school also is a good idea. I mean, especially if you're really busy in university, but still, your work, what kind of work did you do? Have you done anything other than study? Are you capable of handling the load? Because again, that's something else they're looking for. Can you handle the mental cognitive load? Again, it's not, are you the most brilliant, student there, but it's, can you handle the sheer cognitive load? Because obviously being a physician requires you to handle many, many things coming in at you at once, and you need to be able to solve a lot of problems simultaneously. You need to be able to multitask, even though we know that's not exactly a thing, but can you quickly switch? And that's also an important skill. When we talk about cognition, executive function, how good is your executive function? That's something else important to keep in mind. Have you done research studies? Did you help? Even if you're the 28th name out of 28 names, you still were involved in research studies. That also matters. So finding somebody to work with to do research studies to help you get in. How did you do in your psychology or sociology? Because on the MCAT, there are questions about psychology and sociology. They're not equally weighted, but they're definitely there. All right. And remember, each medical school is different. This is a generic med school. This is, state med. Okay? So you need to do the research first, but of course you would. All right. What about having a 4.0? Absolutely not necessary. Your science GPA carries more weight. But if you want to get into Harvard, Yale, any of the big names, definitely helps. Allopathic medical schools, on average, they would like a 3.9 or better. But it's not an absolute, especially if some of the other components are there. Your science GPA, there you're looking, they want something like a 3.75, 3.8, and that's your science GPA, of course, is all the science courses that you've taken, because that's key. Now in an osteopathic medical school, they like a GPA of, 3.5, 3.65. Your science GPA, they're looking for like a 3.75. You still need to be a solid science student. So which way would make you happier? That's a fair question. Would MD, DO, which would a student interested more in the holistic, preventative, kind of like family medicine, kind of taking care of like a more rural community or a community, or studying, food as medicine, nutritional medicine, that kind of thing, definitely would fit and feel more comfortable with DO philosophy. Whereas those who are interested in the latest experimental procedure, using laser, or like, using virus therapy, that kind of thing, or, picking up a scalpel and cutting, stab to life, as I've mentioned before, that's an allopathic path. It doesn't mean you can't do it if you are, on the DO side or the MD side, can't be a holistic physician, but you may feel more comfortable in those environments. Again, each person's individual, and so you need to ask yourself which way you want to go. trick. This is the part that really is what makes the difference. Whether we like it or not, it's the MCAT that really makes significant, gets you in or not. Whether you're going to an allopathic or osteopathic medical school. So the medical college admission test, it is a multiple choice examination. It takes around 7 hours to finish. There are 230 questions. They're divided into 4 sections: chemical and physical foundations of biological systems, critical analysis and reasoning skills, biological and biochemical foundations of living systems, psychological, social, and biological foundations of behavior. These subjects are not weighted statistically evenly. Obviously, the biological, biochemical side counts for about 65% of the exam. And chemistry being next most heavily weighted. Physicians and surgeons are applied biochemists after all. So, first time average MCAT score is 500. Likely this isn't going to get you in an allopathic medical school, but if you've got enough strength on the other sides, who knows? A score that will get you into somewhere is around 511, 512. And remember, they also like to see that the scores are a little more evenly weighted. Again, that roundedness. Are you capable of handling that kind of flexible thinking? It's important to know that. Now, a score of above like 515, 517 adjusted, that definitely will make a difference. For DO programs, they'll take from 500, 506. And if you get like a 508, 509, you can get into the more prestigious DO programs. AT Still, PCOM, CCOM, North Texas, Michigan State, the names that are more well known. Keep in mind, they do have a very different philosophy in what they're looking for. Okay. They tend to look more for the holistic thinkers, and so they be a little more flexible with all the different scores and things, because they know that maybe those they're looking for may be older, or maybe out of the box kind of thinkers, or maybe having different interests or second career, that kind of thing. So just something to keep in mind. They're looking for somebody who's a little different from the typical medical student, but is still a good scientist. That matters. What kind of thinker, what kind of person you are. Ethical, understand the value of science, or scientifically minded person, but maybe, here or there a little bit of, okay? So they definitely, the DO programs tend to value those people who prioritize more than GPA and standardized scores, but still have that passion, that science passion, and that drive. Because again, they still have to be, focused on their patient, making them well, and they still use the traditional methods, even if there's a little bit of, play in there. All right. How about being accepted below 500? Is that possible? Maybe, if you really sparkle in some other way. Really. But honestly, the best way then is to retake the exam, study harder, that kind of thing. But studying and scoring above 500 is your best bet. Just one of the things to keep in mind. Okay, so what happens in next? You will, after you complete that, you will send one primary application through a central application service to make the process simpler. Students a number of years ago had requested that there be a centralized system that processes all the stuff that's necessary to go to medical schools. And so the AMC, what is it, the AMCAS or the AACOMAS. So the AMCAS handles the primary application if the student is applying to an allopathic medical school, and the AACOMAS handles it if it's osteopathic. And so what happens is they'll collate everything together, and they will send a primary application based on schools you check off, and you send them all the stuff. Yeah, they'll take your MCAT score, they'll take your GPA, your undergraduate studies, anything from anywhere else, any research you did, any volunteering, any occupational materials, everything. Stuff it all together, and they'll send it to the schools that you've selected. And then you got to wait. You'll hear back if anyone's interested in you. You'll get a secondary application coming back at you from those who say, you know what? We like you. We like the cut of your jib, as it were. So you get a secondary application, and you have to respond quickly. You only have a very short window because they've got others that they like too. So you fill out this, yes, I want to go to your school. And they will ask you things in essay format like, hey, why us? Why did you pick us? And, because you took me. That's not okay. You have to have an answer as to what interested you about that school. So you'll write an essay, why you want to be a doctor, all that kind of stuff. Even if you wrote that already, they want you to kind of hone in on more specific reasons. And you send that off. You say, yes, I'm interested in going to your school. Maybe they have a good research program. Maybe they're more holistic. Maybe they're whatever. And so you will, you'll have, along with the other stuff you send, you'll have like 6 letters of evaluation, recommendation, personal statements, all that kind of stuff. And so then you will wait to hear if they want to do an interview, either personal or kind of a round robin kind of thing, where you'll answer their kind of questions, and now you wait again. Usually this one's faster. They vote. Do they want to take you? They taking someone else? So now comes the hard part. If you're accepted, you say yes, or, does no one take you? That definitely happens to a lot of people. Again, medical school, very, very competitive. If they take you, celebrate. If not, maybe you try again next year. Maybe it's time to consider that master's in underwater basket weaving. All right, now congratulations, you made it into medical school, and you're already thinking about what next. What will you do after you complete medical school? And the reason is because it's 4 years, and those 4 years are going to fly by because you're going to be very busy during these next 4 years. The first year is actually probably the easiest, and the fourth year is next easiest. But you're still going to be really busy. So students in medical school that are interested in becoming physicians, obviously because they're in medical school, already know what kind of residency, which is what they're going to do after they complete medical school, already usually know what kind of residency they're going to want. So their eyes are already on what the prerequisites are going to be for their residency when they start. Now, there are going to be those students who are like, I'm interested in this and this, but, it's like, so they'll make those choices. But most students already know what kind of doctor they want to be, and that residency is what's going to shape that in the long run. So, yeah, the first 2 years of medical school are mostly didactic, classroom-based learning, and are founded on those kind of classes that will teach them the fundamentals, the essentials of medical sciences. When they were undergraduate, they're more general sciences for any kind of scientific career. But now those sciences are focused on building their understanding of medicine itself. So MS1 or Medical Sciences 1 first year, they'll take gross anatomy, embryology, histology, cell biology, biochemistry, although that's now being more towards undergraduate, genetics, physiology, immunology, microbiology. They also learn how to perform physical examinations, patient histories, and they're learning the basics of how medical system works. And it doesn't matter whether they're in allopathic or osteopathic medical school, it's pretty much the same for the first year. And the reason is because there is a 3-part high-stakes examination they're gonna have to take the first part at the end of the second year. And it's a 3-part exam, so they're going to take the first part at the end of the second year, the second part at the end of the fourth year, and they're going to take the third and final part after they complete their internship, after they graduate. So it's a complicated exam that will grant them their independent license to practice as a physician. So they're going to be concentrating hard on that as well. All right. So after they've completed their first year and all these kind of basic studies, in their second year, they're starting then to learn specific organ systems. Cardiovascular, neurological, they're learning the endocrine system, they're learning skeletal, all that different kind of stuff. And they also are then studying pharmacology, medications, what they do, what kind of systems, and advanced clinical skills to prepare them for their clerkships, which they'll start in the third year, and where they kind of are moving out of the classroom focus and into learning the hands-on components of what it takes to be a physician. They are going to be doing like labs and other things where they practice some of the different level basic skills that they're going to start then also for the clerkships and learn those kind of things that they need to know, so they can do their rotations in the different units in the hospital and for the different practices they'll do, because they really need to work on all the different basic and foundational skills that as they move into. They also now will get a large chunk of time to focus on passing that first step of either the U.S. Medical Licensing Exam Part 1 or COMLEX USA Part 1, which are the first part of their licensing exam. This first part will be testing on their essential cognitive understanding of these foundational assessment of the foundational physiology and chemistry, biochemistry, pharmacy, immunology, pathology, diseases, all that kind of stuff. Again, the foundational skills, and that's what they're going to be studying. This is a very hard exam. No denying it's very hard. And it really is part of what their residency programs that they'll be looking at. One of the things they're going to look at. We'll get to that in just a moment. Not everything was crunch and grind in that second year. There is some cute, positive kind of things, and you may have seen or heard this on TV dramas and things like that. The white coat ceremony happens. It's actually a very recent thing. This was not a long historical thing. They'll receive their white coat with a patch on it from their school, and, it's like acknowledging, hey, guys, you've done a good job for these first 2 years. You worked, you passed, you're ready to go out there. You're ready to start feeling what it's like to be a physician. It's like I said, it's really cute. You get the pictures of the students in front of the med school, and mom, dad drop by, or whoever. So yeah, this is kind of a neat little, yeah. Like I said, it's fairly recent. Only within the last 30 years, 40 years have schools started doing this kind of thing, but I think it's neat. Many other medical professions do this. They do this with nursing. They do this with PAs and NPs and stuff like that. It's a way of acknowledging having done hard work, and now you're ready to get out of the classroom environment and move into actual beginnings of patient care. Mainly when you start to do these things, you're just eyes, you're watching and learning, you're writing, you're studying still a lot, but it is a progressive kind of thing. All right, let's talk about the USMLE Step 1, and we'll talk about the COMLEX. It's an 8 hours long. It's a very grueling exam, which will look at your fundamental medical knowledge. It's divided into several sections. Knowledge of the medical sciences, physiology, microbiology, histology, immunology, pathology, biochemistry, nutrition, behavioral sciences, and ethics. It's, like I said, multiple choice. It is technically pass-fail, but you still get a score. And that score goes into the things that a residency program will look at and say, hey, should I take this person? Should I take that? But for the schools, it's pass-fail. Do you move on or not? That's really important. For DO programs, there's a different exam called the COMLEX USA Part 1, and it's same stuff. And pass-fail. And there are 2 blocks of 4 hours each. You get a 10-minute break between. Not much, just enough to go to the bathroom, maybe get a drink, and we're right back in there. Same thing. Pass-fail with a score, which weighs into your what kind of residency program you get. But remember, these tests, these 3 parts, what they do is they affect, what kind of residency program you get, which is essential for you being able to move on in your career and for you even getting a license. So, all right, now moving into your 3rd year. You've completed that, and now you're ready for medical school year 3. You're going to be hands-on. You start your what's called a clinical clerk, and you'll go through a series of different rotations. They go anywhere from 8 to 12 weeks, and what's typical is internal medicine, which is studying diseases of the internal organ systems. Surgery, you learn very basic kind of skills like to place central lines, arterial lines, and the basic suturing, stuff like that. A lot of watching is happening here too. Pediatrics, OBGYN, psychiatry, family medicine, learning about comprehensive primary care in an outpatient setting, neurology, learn about disorders of the nervous system. These things are like anywhere from internal medicine and surgeries, 8 to 12 weeks, OBGYN, 6 to 8 weeks, psychiatry is 4 to 6, neurology is 2 to 6 weeks. Again, the goal is not to make you a specialist here. The goal is to get your feet wet so you kind of have an idea what's going on. Mostly watching. You, as a clinical clerk, will pre-round, which means before formal rounds in the hospital where the residents and the attendings go through, check on patients and look at the charts and everything else. You will look at the charts. You may be assigned 2 or 3 patients to just quickly, look at, answer questions. Your resident, the senior resident or your chief resident, we'll get to that, will say, hey, I want you to look at these 3 patients. Tell me what you think is going on. I want you to tell me what you would do, how you would treat them. And I want you to answer these clinical questions. They're not expecting you to actually do anything with them. Not really. But, they'll listen to what you have to say. They'll, ask these kind of questions. They want you to start to think like a physician. You're not just doing lab exercises. They also may have you do suturing. They may have you do simple procedures, like if the patient has, they may have, a wound or whatever. They may have you do a basic procedure. They may even have you start an IV line or, something basic. They may have you look at an EKG. What do you see? What do you think? I'll have you maybe look at x-rays, things like that. Just really basic and under supervision. You do not have a formal license of any sort yet. That's what the USMLE is all about. But you still, have a training license, kind of like a learner's permit for driving a car. So, again, it's like this is how you're learning to bridge that gap. You also take what are called shelf exams. This is practicing for the next stage of testing. The shelf exams are complete every time you complete a rotation. A shelf exam is a multiple choice exam which is very narrowly focused on that specialty. It's a multiple choice. It's commercially made. It's psychometrically accurate, and it's preparing you when you're going to take the USMLE Step 2 or COMLEX Step 2. But they see how you're doing. You also get an evaluation note, something like that, saying, you did well in this thing, and that also will count towards your residency, which is, your next step here. And so this also helps you think about other specialties you may be interested in. Medical school in the end is designed to make you a general physician for when you get done. Your goal is not to be a specialist with this. The license you get for the state allows you to practice general medicine. And you're not trying to practice to be, like a neurologist or, an orthopedic surgeon or anything. It's just to be a general practice physician. That's it. But, you get enough experience to know all these different areas because that's upon what your residency is built, this general knowledge. Osteopathic medical school, they take extra courses in things like osteopathic manipulation, holistic medicine, food as medicine, things like that. But that's one of the differences between the two. The science and medical foundations are exactly the same. Same courses, same textbooks. You can even look it up online, the kind of books they take, the texts, the curricula, all that stuff. All right. Now moving on, the fourth year. This is where things are become real, because these are two major things that happen that Well, first of all, you do have to take emergency medicine, critical care medicine, and you'll get some elective rotations. These are requirements. However, many schools have a sub-internship or sub-I, which is like a dress rehearsal or an audition for a residency. You often would apply for these and say, hey, I want to do a sub-internship at that hospital or in that program. And it shows any potential internship or any potential residency program, because the first year of your residency is called an internship. And it's a chance for you to show that you have the skills necessary to perform as a general physician, and it preps you for the last step of the U.S. medical licensing exam or COMLEX exam, which is essential for you to get a complete license, for you to apply for a medical license. If you don't have that, you cannot practice medicine. This is a sticking point still, legally. So, it's like you have to demonstrate. And a sub-I is a good way of showing that you're diligent, hardworking, that you follow through, things like that. So what happens is, if you get into, any of these kind of sub-Is, these sub-internships, you will essentially manage a small set of patients kind of independently. I mean, you still don't have that license that you could. However, you can, you'll be given 2 or 3 by a resident, and they'll be the easier ones, not something that would require a senior resident to manage or an attending. And, you write down, it's like, this is what I think should be done. This is, kind of like you did back when you were a clinical clerk in third year, and, what kind of treatment is necessary, your interpretation of test information, of their lab work, radiology, all that stuff. And, then you present your your ongoing information during these weeks while you're doing your sub-I. And it also gives you a chance to make contact with those who would write a recommendation for you when it's time to apply for your residency. And so it is kind of different in that you're not necessarily accepted into a residency program, but it can make that difference. You also are going to take OSCE's objective skill assessments, which demonstrate competency. So this is a crunch year 2. It's just not quite as bad as when you're quickly rotating through in the 3rd or 2nd year. You also are now preparing to get into a residency program as you complete that, because you have to take USMLE Step 2, and you also have to apply to get into a residency program. So USMLE Step 2, CK, clinical knowledge, will test what you understand from your internal medicine, your surgery, your pediatrics, your OBGYN, neurology, psychiatry, all of these things. So multiple choice assessment. It's a 9-hour test. And a total of 16 30-minute blocks of questions. Passing score is 218 out of 300. Passing. That doesn't necessarily mean that it's desirable for a residency program, especially a more challenging one. But that score is what score you get on the CK for the USMLE. That makes the difference for what you get, because that's part of how you apply for your residency. You get several weeks to study again. Now, there's no specific, time to apply for that, but you need to do it before. There is a set time to apply for residency. So, the COMLEX USA CE is that equivalent, the COMLEX, for becoming a DO. It works in a similar fashion. It's a computer-based exam over a day, which assesses a student's ability to apply osteopathic medical knowledge to various clients and treatment. You're given a score from 9 to 999, and the mean score is 500. Again, same thing. It's really the score that decides how you'll match for your residency, and if you apply for fellowship, which comes after a residency, which further narrows your practice. Apart from the MCAT, which got you into medical school, this is the most important set of tests. Every school's different, so just understand it. The other important thing is preparation for match. You need to send your applications and materials to what's called ERAS. And they're the organization that assists in helping you and the residency programs make a connection. In March, at the very end, when it's your senior year in med school, comes the notorious match day. Anyone who's ever worked in a hospital is aware of match day, and you may hear of it on the news occasionally. This is when everything comes together. The final rank ordered list, FROL, is released by the National Residency Match Program. They're the ones who put the list together, who assemble and release that list on match day. And it can be a day of major celebration for vast majority medical students and the residents, potential residents looking for residencies and fellowships. It's not always the same day in March, but it does land around the Ides of March. Somehow that makes sense, doesn't it? To match, a student has to send in an application to their desired residency program, either for medicine or surgery. They send their applications through ERAS, as well as personal statements, medical school grades, the USMLE or COMLEX scores. DO students can take the USMLE if they want. Your medical school performance evaluation, which comes from your medical school's director. Letters of recommendation. You need 3 or 4 of them. Any research or volunteer work you've done while in medical school. They're mainly interested in like the 3rd, 4th year, but any kind of, any foreign exchange medical studies, as well as any medical work or certifications. The process is almost the same for fellowship programs, too. Now, there are some designated DO residency spots at some hospitals because the vast majority of residency programs are primarily aimed at students from MD programs, but, it's like... So, a residency program, many of them are run through the largest hospitals or specific medical practices and institutions that teach these doctors to be specialists in their field. The residency programs themselves need to be approved. And they're funded through the federal government, usually through Medicare, Medicaid, or the VA, Health and Human Services, just because it's so expensive to operate a residency program. So cuts to Medicaid, cuts to Medicare affect physician training. Important to keep that in mind. Medicare, Medicaid isn't just for taking care of the poor, indigent, or elderly. It also provides a significant portion of physician training. Just so you're aware of that. Unfortunately, every year about 5 to 7% of medical students, MD students, and 7 to 10% of DO students fail to match. This is a big problem. They do have a chance to fix things first during that week in a process called SOAP, Supplemental Offer and Assistance Program. This enables them to try to match into specialties, residency programs that did not fill all their spots. This is a last chance and fast process of finding the best spots in these unfilled residencies. They may not be filled for many different reasons. Students did not accept their residency program. Somebody got sick, whatever. There are a lot of different reasons. Or it's an undesirable specialty. Or there just weren't as many medical students that year. Something happened. Maybe like with COVID or something, there were a few extra spots. Could be for many different reasons. Thing is, during this key week, you want to try to, pick something that's as desirable. They call this fast-moving time the scramble. And sometimes a student still fails to find a program. No one takes a student. That is extremely serious because you need to complete your internship so you can take that 3rd and final step for licensing, your residency. Because if you don't, you cannot practice medicine. You'll have your MD after your name, but you cannot practice. And that does happen. Sometimes a couple thousand students a year. Some states are working on fixing this. And, finally, after you've matched, after you know where you're going to go for your internship, which is the first year of your residency, either to another hospital and going to do an independent internship and then go to where you're going to do your residency, or an integrated residency, which is most typical, where that first year is done at the same place you're going to complete your residency training. But there are some separated programs too. Again, each school does things a little bit differently. Congratulations, you finished medical school. You're now Dr. So-and-so. You've gotten your doctorate, which is, doctor means, it comes from Latin docere, meaning to teach. It doesn't mean physician. It's not the same word. Physician is, a medical doctorate, but there are other kinds of doctorates. So the word doctor does not mean medical practitioner. It means that you have the highest academic degree in your discipline. Just remember that doctor and physician are not the same word. It just comes from Latin, meaning to teach. There are other physician degrees, like from the UK. You may see some of these if you're in a large practice. If you're here in the States and someone is training, the MBBS. That is a bachelor's degree in medicine. The bachelor in medicine and bachelor's of surgery. And those students go right from high school to medical school. They don't do the undergraduate, or they don't do the doctoral program. Rather, what they do is they go from high school to medical school, and they get their basic sciences while they're in medical school. They still have the same knowledge, it's just structured differently. But doctor, physician, not the same thing. It's physicians that we're talking about, and surgeons. When it comes to helping someone to develop what it takes to become a physician, it is really at the residency and fellowship that they go from the skills to become a physician to being shaped into what it takes to be a specialist. This is more like an apprenticeship at this point. The differences between any kind of MD, DO, whatever, after they finish medical school, they really are, ivory tower knowledgeable. But when it comes to putting your hands on somebody, this is where the difference is made. So let's talk about the process. We briefly mentioned internships, but let's go a little further. First, residency varies from anywhere from 3 to 11 years after medical school. So the first major thing to understand is that when you start your residency program, you are now paid. Not much. Your stipend is itty bitty, but you are considered a working physician, because what's going to happen as you progress through, and when you get your medical license as a general physician, you are then a licensed medical professional. But you're not a specialist in the area you're studying, but you are going to be paid by your program. Typically like $60,000, $50,000. I mean, heck, a brand new nurse makes more than that. But that's not the point. You are there to learn. Yes, you will provide some basic, physician care, but not as a specialist, not initially. And that's what the difference is. So, the first year of residency is your internship year. You see somebody schlepping around inside your hospital caring for you with a badge that says intern or medical intern. It's their first year residency. Okay. And their goal, there are two different types. There's the surgical internship and there's a medical internship. The student is still going to be much more independent at this point. They will have their patients, they will have people, they still have supervision because they don't have that independent license yet, but they will rotate through the general floors. They will be doing some of what they're interested in. Like if they're a student neurologist, neurosurgeon, whatever, they will definitely be learning some of the foundational skills, but they also have to show that they understand and that they are ready for an independent practice license. So they'll do all the stuff we mentioned about, neurology, psychiatry, OBGYN, you know, internal medicine, everything throughout the stuff we mentioned. It may be a couple months, maybe most. And then finally, you reach the end of their medical. If they're doing the medical, then they will sit for either the USMLE Step 3 or the COMLEX Part 3. It's a series of, for the USMLE Step 3, it's a 2-day test. First part is called the Foundation of Independent Practice. It's a series of 232 multiple choice questions, and it's focused on patient safety, ethics, biostats, and basic medical sciences. The second part of the test is called Advanced Clinical Practice. It consists of 180 multiple choice questions and 13 computer-based patient simulations where they have to figure out what's the patient's problem and what the treatment is. Test is divided in half. Each part is 7 hours long. Passing score is 200. The average test taker score is 227. It ranges from 3 to 300. The equivalent of Step 3 for students who are DO, osteopathic medicine practitioners. It's called COMLEX USA, Level 3. Or Part 3, sorry. And the USMLE Step, and their equivalent is also 2-day examination. First day focuses on fundamentals of medicine. Test contains multiple choice questions, biomedical, osteopathic, clinical knowledge. 280 questions on that first test. Second day, second part of the exam is a clinical decision-making test. And second part, examination, is then subdivided into 2 sections. First part, they make, the test is 26 patient cases, divided into 2 sections, 13 each. GO candidate must answer the questions in the form of short essay or extended multiple choice questions. Each case features 4 questions, similar to the USMLE 3, second part. Second section is composed of 140 multiple choice questions. You have 3.5 hours to complete these case-related questions. Score range for the COMLEX Step 3 is 9 to 999. Passing score is 350. Most students earn 570 to 580 score for the COMLEX. And so, it makes no difference with regard to your practice, just as long as you pass. And so that's what allows you to get your licensure. After you finish, do want to quickly mention that the surgical internship is, you still have to know the things that you do for your medical internship. You still have to be able to answer the same questions because that's what they throw at you. But you also will learn suturing, opening, closing, placement of lines. You have to be able to do the very basic stuff. Things that a medical first assistant would know. Electrocautery, stopping bleeders, things like that. The essential basics, because they will teach you procedures and how to dig down when you do the actual residency. But you've got to know how to at least be useful, because they're going to move pretty quickly. And time flies for this too. It may seem like a long time if you're not doing it, but when you're busy learning how, and as you quickly move up, you'll be teaching others and you'll be supervising others. And so it moves fast. So you better know and learn quickly. Many medical students, residents, fellows describe it as drinking from a fire hose. For good reason. Not much time and a lot to learn. All right. So the focus now shifts into the specialty training. Since the residency is postgraduate, that is, you've already graduated from medical school, they'll use the term PGY, postgraduate year. So if you see something said like PGY2 or PGY3, what they're talking about is that this residency is a postgraduate study. So you may see PGY whatever, and so if you see it on a badge or printed somewhere else, they're referring to the fact that they've graduated from medical school, and it's now postgraduate year. Now the internship is PGY 1. So after that, it'll be PGY 2, 3, 4, but most you'll see like their badge will say resident, neurology resident, neurosurgical resident, whatever. And it tells you they're on their path to becoming a specialist. A resident is called Dr. So-and-so because they've completed their medical school doctorate, their doctorate from medical school. Okay? They're just not specialists yet. Okay? A junior resident is fresh, brand new, just starting. Whether their program is only a couple years long or whether it is 9, 10 years long, a junior resident is brand new. Okay. So, PGY2. Remember, postgraduate year 2, they're new. The resident physician starts working if they're working in medical, their job mainly is to listen, to learn while they're a young resident. Their jobs to learn from everyone. The nurses are specialists in their department. Their jobs to learn from them. To learn from other experts in the field. They'll have still a lot of reading to do, writing to do. They'll know at least a few things, but they're still in some ways like new medical students, kind of, because of the sheer amount of absorption they have. Difference being they have their medical license. They have a specific focus. They also are now starting to learn about more serious problems related to that specialty, more than just surface information. They're now going to be learning, so if they're in neurology, and at that level, they're actually making decisions. While they may have the less serious cases, they're actually going to be giving orders. They're going to be... the thing to know is they still will have to talk to the attending or senior residents or chief residents, which are the ones who are ready to become attending doctors, attending physicians. But they actually will be providing orders and writing prescriptions and providing direct care for the patient rather than simply watching and listening. They now are going to be making, this patient needs this medication, this patient needs this. And so unless there's a mistake, they generally have their own patients here at this level. And, so it's like, but they still are reading a lot, studying a lot, and so they may write for journals, mentor medical students. They may they may go abroad to work with, say, a British hospital or, go to Japan or whatever may be part of their program. Especially for some of those programs that have like an extended research period or whatever. Do they are they thinking about narrowing their focus? If they're a neurologist, maybe they're thinking about being, an epileptologist or a brain injury medicine specialist. We will talk about that with some other videos. Then though, especially with the longer programs, and there's that kind of mid-level resident who now actually, they can handle a lot of the middle, or a lot of the minor to moderate severity problems that a patient would have. And in that middle level, they're learning perhaps about some of the technologies and how to do some of the side specialties. They may learn how to use interventional radiological technologies or how to read different kinds of scans. They may be in charge of like the neurophys lab. They'll learn how to interpret certain things, and they'll be teaching. Throughout the residency program, that is something that residents do a lot of. They will teach more and more. They may teach new medical students or junior residents, as they move along. That is a significant. They may end up being consulting for the ED in their specialty. They may teach, classes for PAs or nurse practitioners. They may do a lot of different things. They may teach like one-offs, or they may attend and present the attending's poster, or some kind of lecture on their behalf. They will do their own research too. So a lot of things to do at that middle level. Then finally, as they reach the end of the program, as they're looking towards getting ready to graduate from the residency program, they're studying, especially if they have an interest in either becoming a fellow or if they want to, if they want to do research, or they want to do something, maybe they're going to do another residency, or they're doing parallel residencies, or if they want to be board certified, they've got more studying to do. And these days, 90% of physicians become board certified, so there's studying involved in that. When they're the senior resident or chief resident, which either is used simultaneously in some programs where senior and chief resident are kind of the same thing. Surgery, they do differentiate that more than medical programs, although, again, each one is different. But at that point, they're teaching a lot. They diagnose and handle the most complicated cases. They're pretty much on their own. They're like a year from becoming an attending, so it's just a little bit of polishing off. And they may do the highest, and they're learning the most advanced procedures, things like that. They're at that level, they're practically indistinguishable, with a little bit of exception from an attending physician who is a fully licensed, certified practicing physician in the field. And at that point, like I said, they're mostly teaching or doing studies, and and then they graduate. They graduate from their program, and then they'll take, many of them, this is something important. The board certification exam may have a requirement that they can't be fully certified till they practice for a while. Some programs require to be a board certified physician in neurology or neurosurgery, whatever, may say, hey, you need to practice for 3 years before. Others say you can only take this exam for up to 5 years after you graduate. So you need to know what the requirements are, and you need to study. And the purpose of board certification, you get your diploma. And this diploma says, hey, you've seen that, if you've been in any physician's office, they have their medical school diploma. They've got their undergraduate degree there. And then they'll often have these other papers up. Usually they'll have their license, which they got by passing the USMLE steps 1, 2, and 3, or their COMLEX 1, 2, and 3. They also then may have several diplomas which reflect the fact that they are board certified. Now, board certification comes through a private corporation, usually, throughout the country, which is established by groups of very experienced physicians who've laid down what it takes to be board certified. And that means they are experts in their resident field, like neurology, neurosurgery, whatever. And some also require it in order to become a fellow, which we're about to get to in a moment. Okay? So, if you're going to take your fellowship or whatever, you need to have that. But it's a very difficult exam, very, very difficult exam. And you may have to demonstrate that you're even competent enough to take that exam. So you may have to take 2 exams. Like I said, Surgical residency, as we said, it's like they still have to demonstrate. So we're shifting gears for a moment here. You first have to go through that initial process of showing that you've got the skills, and you have to learn how to perform the basic. So the first year or two during surgical internship not only involves what it takes to be general practice physician, surgical resident, but you got to learn instruments, how to do incisions, knot tying, placement of invasive lines, tubes, all that good stuff. You also have to learn infection control, how to avoid, making your patient worse, obviously. You have to know all the equipment. You have to know how to work with, other people who are in the operating room appropriately. You've got to know how to do pre and post-op assessments, tracking surgical anatomy, which is a little different from, interventional radiological, all that kind of stuff. Very important. Some of these skills are actually taught to highly specialized nurses who've been practicing for a while. I had my first assist for trauma. You can't get that right away. You need to be practicing for a while. Even the first assist nurse can subspecialize. Anyway, after completing internship year and your junior residency, the surgical resident then will take their USMLE step 3. So in some cases, they have to wait an extra year before they take that. A young surgeon now will move into their middle residency, where they learn things like the important procedures related to surgery, no matter what, and they'll assist the chief resident or the attending in performing the different aspects of the more complicated procedures. It's important for them to assist so they see things that they need to. They may perform interventional or some of the simple procedures on their own, things like appendectomy, gallbladder removal, and stopping more minor bleeding too. As they move up in their residency, they'll teach medical students, younger students, participate more in surgical research, things like that. The general surgical resident, which is what I'm focusing. They move through blocks of different types of surgery, like thoracic, abdominal, pediatric surgery, OBGYN, and perhaps, some neurosurgery. A general surgeon is not studying to become a specialist at this point. Quite literally, as the name suggests, a surgeon that can perform the most common types of surgery on a patient that they might need would be a general surgeon. If a general surgeon wants to become a specialist surgeon, then they have to take a surgical fellowship. As I said, we will get to fellowships in a little bit. As they reach the senior and chief resident levels, a general surgical resident performs a vast majority of the most difficult surgery, and they'll lead in the surgical ICU, and they'll teach the new resident and medical students as they rotate through surgery. When a chief surgical resident finishes their last year, like the senior medical resident, they make the same choices. Should I apply to a fellowship program? Or should I apply for a job at the hospital as an attending general surgeon? Keep in mind, their residency is as an attending general surgeon, so they perform more. But due to the complexity of surgery, it requires you to take another step to become a specialist. Now, there are some surgeons who have to, from the very beginning, go right in as specialists, but most of them will go through first being a general surgeon. Neurosurgery is one of those that starts immediately, but many fellowships require residents to take their board certification in general surgery, and then you go from there. So it's really, really hard becoming a surgeon of any sort. Really hard. Board eligible versus board certified. So after you graduate from your residency program, this applies to all physicians. You can find a job as an attending physician or surgeon. This doesn't, again, asterisk. For the first 5 to 7 years, depending on your residency, you are what is called board eligible. Board eligible means that you could take a certification exam to demonstrate competency in your specialty. The examination is not a requirement by state law, usually. You can practice without it, but insurance companies and many hospitals and group medical practices or fellowships may require that you take it and to become certified. As I mentioned before, the board exam is written by a group of experts in the field and heavily vetted. Sorry, I apologize for that. Is heavily vetted psychometrically to ensure it is a valid and reliable examination. Okay. If you're interested in the particulars, you can always visit the American Board of Medical Specialties. The ABMS will lay out, what's, required. The certification will, of course, vary depending on the kind of specialty. Those who pass one of these exams or a subspecialty certification, which they also provide, are referred to as diplomates, as I mentioned before. Those that deal with high-risk care, surgical, emergency, anesthesia, may also have to complete a simulation. Patients or actors and they have to answer another test, as I mentioned. Some of the docs that I know personally have said this was the hardest exam they've ever taken. It's almost in some ways like defending your PhD thesis or the bar exam to practice before the bench. There are oral questions in some cases. So, after passing your boards, like I said, you may find this among the stuff that they hang up, which would make sense. All right. So I think this will at some point become a universal requirement for almost like a licensure requirement for if you have your residency. I don't know. Fellowship. There are physicians who are interested in going beyond their residency and becoming subspecialists. They study in a very narrow area called taking your fellowship. This is what it's called. Fellowship can last anywhere from 1 to 3 years beyond your residency. It's typically, and many of these are offered by the same places that offer, a residency program. So what you have to do, it's kind of the same thing. You update your curriculum. You send your general application, your CV, other paperwork, to the fellowship programs. You apply through the same ERAS system. Your medical school grades, USMLE scores or COMLEX scores. You need 3 or 4 strong letters of recommendation from your residency program now. Professors, physicians, and subspecialty. One must be from your residency program director. Telling them you did really well. These need to go in early, especially if it's a competitive fellowship. As the same with the residency program, the fellowship programs notify the National Residency, the NRMP, in September, and that they're going to be sending out the fellowship match list. You wait until match day. You hear obviously differently, but you still wait for match day and are told, hooray, you're a fellow. Congratulations. Welcome. You still have to interview. Everything's pretty much the same because it's still a type of residency. It just is with an experienced specialist now. If somebody has completed a fellowship, they're already usually either they're coming right out of a residency program because some specialties require this subspecialty training, or they're an experienced doc who's decided, hey, I want to, narrow what I do. So as with residency, it's Most current fellowships, though, are about 1 to 2 years, which is different. But a fellowship trains these specialists. Fellowship programs typically include advanced clinical care practice. They spend the bulk of their time working with experts who deal with the most seriously ill or injured patients. Care beyond what a general resident would do. Some fellows are found in, like, perhaps a hospital lab, like I'm kind of drawing a blank a bit here. The interventional radiology lab, an electrophysiology lab, seizure labs, something like that, or in highly specialized intensive care units, or working a very unique practice. That kind of thing. They may only work with one type of patient who has a specific disorder, or something along those lines. They're very specialized. And yes, you can go even further than that, but they often learn highly technical procedures, or they'll do specialized research or international work. They may be specialized in education administration. Some may choose to do, which you also can do depending on how you apply to medical school. They may be MD JDs, like medical doctor and lawyer, JD Juris Doctorate, which is the doctorate. Remember, doctor doesn't mean physician. It just means that you have the highest level in your profession. So lawyer, doctor, or MD, DMD, which is often an oral maxillary facial surgeon. So a dentist that also has an MD, and it's because they do surgery. They'll often do that. Or MD PhD, if you're doing research, or DO PhD. I mean, there's nothing that prohibits a DO JD. There are a lot of combined programs like that, where they'll do 1 or 2 years working on their MD, and then they'll complete their JD, or they'll complete their PhD and defend their thesis, then go back and then do the clinical portion. But these are other things. Or they may do a fellowship that contains the bulk of the elements of a residency, because they have the foundation that's necessary for the other residency. Anesthesia, ICU, a lot of the skills tend to overlap. When we discuss specific physicians, we'll get into some of that. They may pursue an MS. They may pursue an MA as well. For example, for hospital administration, there are physician hospital administrators, and master of business. That they may do that, or they may choose. There are neurosurgeons who also have their PhD in neuropsychology. It helps them understand function of the brain as well as anatomy and surgical procedures. It's unusual, but they're out there. So obviously, when you finish your fellowship, you will often then go for, guess what? Yep, your diploma. After you finish this fellowship, you take a subspecialty exam. And again, it's a very high number who take this too. You must first have an unrestricted license to practice. You must have your primary active certification, your diploma, in your residency. Then you take your subspecialty fellowship program. And it really depends on what it is. You first may have to take a qualifying exam, which is a multiple choice exam, And that says, yes, you can go ahead and take your certification exam. If you fail the qualifying exam, you can't even take the certification exam, because these subspecialties are, they're rigorous and highly focused. Specialty boards, each one does it differently. Some may just do a simple, straightforward multiple choice exam. Others may demand, a full-blown oral exam before a board, and you have to demonstrate your skills on patient reenactors. You may have to, for like neurosurgery, for fellowships, require you keep a continuous log of patient treatments. You can't skip. You have to record everything, the decisions you've made. It is considered the most difficult of the fellowship boards. Very hard. So, it's like, again, you're a diplomate within your subspecialty, but you have, it's required by most hospitals if you're, subspecialist, and again, really hard. All right, you finished all that education, and finally, you can become an attending physician. So what is it? Attending physician is a fully educated physician. Except the thing is, physicians and most other of the learned professions are constantly learning. Many of them teach. Many of them will also, teach others, but they will do academic studies. They will publish. They may be on hospital boards. They may be out. They may travel internationally and teach others. There will be conferences, all kinds of things. They are usually a person who spent this much time in school, kind of has the bug for education. And so, they may subspecialize. And yes, that is a thing. There are two ways to do that. It's called either an advanced fellowship or subspecialty, or a focused practice. Now, part of the problem is this point, how it's handled becomes a little... A focused practice is one where you can submit evidence that you've been working on a highly narrow area, maybe brand new technology, maybe a procedure or something you figured out, or like only a small group, or even you've established as a subspecialty. And an advanced fellowship, you can apply for just the same way as, it's like acknowledged by the ACGME, who handles graduate medical education for that kind of thing. They're niche. They're typically only found in the huge hospitals, the international experts. They're the ones who publish like 5 books, 6, just on the one narrow topic, and have like 100 in, more generalized areas within it. So getting in, though, same way, CV, letters of recommendation from your fellowship, and, so, but it's the same thing. It may be a year in length, maybe. You still have to maintain, unrestricted medical license. You still have to not only completed your residency program, you have to have your primary diploma in your specialty, in your primary fellowship. You have to be board certified. You register with ERAS. Your general application for subspecialty. And then you'll hear. Now, these programs may have like a rolling admission whenever Professor so-and-so's got a spot. Or it may be just the same. It's like, Some may not even have a diploma. They're so new. Yeah. So many of these sub specialists, they'll lead large academic departments, research departments, that kind of thing. So, they're usually those with like I said, the MD, PhDs, and they'll teach the fellows and they'll do the research and, that sort of thing. So, focused practice designation. This is more about acknowledging those who put in a lot of work into a very narrow area in which they maybe kind of drifted or developed. And, they'll go to the ABMS and say, hey, look at this. And they'll present all their evidence supporting this kind of thing. That, for example, advanced emergency medicine, ultrasonography, or central nervous system endovascular surgery, or neurological critical care, stuff like that. Those have been acknowledged based on information given to the ABMS as a focused practice. It's not something you go to an advanced fellowship for, although it may become. Some of these are more limited because they don't have a formalized curriculum, training, and all that stuff yet. Not enough research. Brand new. Genetic, regenerative medicine or anything like that. We're just not there yet. But as it develops. So what if the physician develops something new? An emerging specialty certification. It's exactly what it sounds like. They can apply for a specific recognition in a brand new field by going to the American Board of Physician Specialties and request recognition for it. Obviously, it can't be a go-around for the work of a traditionally recognized specialty. But if it's new, for example, disaster or integrative medicine is one of these that is an emerging specialty. And, they may pull together a corporation, which is what these specialty boards are. They're not-for-profit corporations that are developing the standards. Like I said, disaster medicine, integrative medicine, or regenerative medicine, or whatever you want to call it, something like that. It's an attempt to develop a new specialty, and they'll get to define what it will take for future residents or fellows or advanced fellows to become. And then they'll be listed as possessing that unique specialty, and it will grow from there. They will. There are certain things that they will need for that, but, physician scientists, we've mentioned about, PhD programs with physician training. It's like there are programs that will take, as the average medical student's already going to be an academic star. But if there's certain students that they see that are recruited from top academic institutions and around the world, they'll get a full scholarship. And these kind of students will be accepted into a PhD program and an MD program. These are ones who score really high, in their undergraduate. They will often take the MCAT and the graduate record exam. Some cases, they don't even have to take the MCAT. They just will automatically, So, that's one of the routes. And as I mentioned, it's that is definitely one of the things available. We also talked about the MD or DOJD. They will, why would somebody do that? If And why would a person with acquired brain injury be interested? Well, a car accident, or if you were injured in surgery, or something happened to you under anesthesia, or whatever kind of care. A physician attorney, MDDO and JD, and if you're learning in law school, students studying for legal degree or medical degree, they learn. Now, students applying for medical and legal degree do need to have grades acceptable to both. Usually these are combined. But the university which offers it understands that the two different schools cannot have, conflicting demands. So a student accepted into one of these kind of programs must have high GPA, must also pass two of these high-stake exams. Usually the MCAT, which you mentioned, and the LSAT, which is the equivalent to the MCAT, but for acceptance to law school. So the student obviously needs to be so the first and second years, as we said, are your preclinical studies in med school. Third year, you do your law school coursework to learn tort, contract law, and constitutional law. Fourth year, you go back to medical school to pick up your clinical and clerkship classes. Fifth year, any late credits for legal and educational courses and your clinicals. Sixth year is your prep for USMLE Step 3 or COMLEX, and any remaining courses matched for residency. Then, when you graduate, you will be going to your residency training, and you may want to take your bar exam if you plan on practicing law. This is a very demanding degree. Direct admission to medical school. For young students that are, academically gifted, it is possible to do a direct admission program, which leads to a quicker path to finishing medical school. It also reduces the stress of applying. So a high school direct admission program can take students who score really high on their SAT score, and they've shown a consistent GPA well above 3.3 or 3.5 or whatever. It would allow them to enter a Bachelor of Science program, MD, or BSDO, guarantees admission to the medical school if they maintain their GPA above a certain level. That's it. No MCAT, no letters of recommendation, no application, nothing. Just maintain that strong GPA, and you roll right into their medical school. It's kind of like the BSMD degree system that Europe uses. Yeah. So, but it is dependent on strong academic performance throughout. There are other combination programs. There is such a thing as an MD PharmD. So if you want to really focus on like drug development or, that kind of research, MD-DO PharmD. Like I said, they tend to be more your lab specialists. We will discuss pharmacists later, dental medicine, podiatric medicine. That's unusual, but yes, indeed, there are those who are MD-DO, podiatric physicians, dentists. There are few that I'm aware of, PhDs in engineering, MD. They help develop new devices and technologies. But like I said, these are few because, to be honest, engineers think differently than physicians do, but they do exist. All right, so I'm pretty much done here, and yes, this has been probably one of the longest videos I've ever made, but I wanted to make sure to wrap up and close up. So I will say, see you next time on this series when we talk about specific physicians that and what they do and what their focus is and where to go as an ABI survivor. So that you know where to go and how they're taught, how extremely in-depth their training is, and also how shallow it can be at the same time, and why they may not understand, because they have a lot to learn in a short time, surprisingly, and why you need to seek out sometimes fellows or advanced fellows for your specific problem. See you next time. Next Medical Monday.